Walaikum salam, Louna. How are you, Dr. Amar?
Alhamdulillah. How are you, doctor?
I'm good, Alhamdulillah.
Alhamdulillah.
Assalamu alaikum, doctors.
Alaikum salam.
Walaikum salam, Louna. Welcome.
Thank you.
How are you, doctor? Alaikum salam.
Walaikum salam. Walaikum salam.
Welcome.
Good morning, Ms. Louna, Dr. Samira, Dr.
Morning.
Ammar.
Good morning, doctors.
Yeah, your live YouTube is online. I have sent the link to you.
Yeah, I just saw it. Thank you, doctor.
Walaikum salam. Good morning, Louna.
Good morning, Dr. Mirza.
Okay, I welcome you all for this postgraduate research presentation. Our first student is Louna Khaled-Post. She is going to present the research on the topic evaluation of newly glycemic control with IV insulin protocol among post-cardiac and non-cardiac surgeries in critical care patients. It's a retrospective study which is done in Cleveland Clinic. And I request Loana to present. First is about clerkship briefing, followed by research presentation.
Okay.
You can share the slides, Loana.
Yes. But it's disabled, doctor.
1 second. Just
Okay.
it's done. Now you can try that.
Okay. So, shall I start?
Yeah, sure.
Okay. So, welcome all. My name is Louna Khaled-Post. This is the presentation is going to be about my clinical pharmacy clerkship. My clinical pharmacy clerkship site was at Cleveland Clinic Abu Dhabi Hospital, which is the favorable place for any clinical pharmacist to join this hospital. My presentation outline will include general clerkship details, clinical rotations, references, electives, courses, conferences, and workshops, and lastly, our activities. So regarding the general details, our training duration was from 7th July 2019 to 6th February 2020, with the training hours of 8 a.m. to 5 p.m. Exceptional days, we stayed sometimes till 7 o'clock evening. The pharmacist in charge was Dr. Usama Tabara, and 4 cases were submitted to the college from each clinical rotation, and 1 report for the electives. Regarding the advantages, they are really endless. I tried to conclude some of them. Like, for example, the training was applicable to improve knowledge, which is taught theoretically by the college. It is a very highly recommended place to join as a clinical pharmacy field. I gained a huge practical, useful knowledge in addition to the teamwork and leadership taught by the hospital. Disadvantages were few, but for example, I can share with you that not all areas were available and covered equally. So like sometimes we covered some 2 weeks, for example, and some were 1 month. So we will start with the clinical rotations, where my first clinical rotation is the cardiology rotation. Actually, we started with regular morning rounds with the cardiology team after personal revision of the cardiology ward by myself. And the afternoon was the heart failure clinic and the anticoagulation clinic, where we go with the clinical pharmacist for consulting the patients after we take the INR of them for the patients who's taking anti-coagulation medications. And then we consult upon each patient. We do also daily cases, topic discussions, and weekly DI questions. Our instructors were Dr. Ziyad Sadiq and Dr. Bissam Atallah. Topic discussions included some heart diseases and cardiovascular problems like acute coronary syndromes, chronic heart failures, hyperlipidemia. And I had a presentation with the cardiology team, with the physician, about the anti-diabetic medications used in heart failure patients that will reduce morbidity, mortality, and hospitalization. Presentations I did at the hospital and in the college was heart transplantation and heart failure, and these were the references I used. My second rotation was the cardiac ICU rotation. Again, we did regular morning rounds, similar daily cases, topic discussions, and DI questions. My instructor was Dr. Janice Phillips. Presentations were CABG and ABR surgeries. Topics were targeting critical illness patients like fast hug, pharmacokinetics in critical illness patients, vasopressors, sepsis, pain, agitation, delirium, ACLS. The project I did there that was data collection for a project was undergoing in the cardiac ICU about the effect of vasopressors on ischemic colitis in critical illness patients, and I wrote a full summary on it. And the references I used were here. During this rotation, I had the chance to attend aortic valve replacement surgery where the duration was 7 hours. My third rotation was internal medicine rotations. Unfortunately, I didn't have the chance to go for real rounds, so I did virtual rounds after revising by myself. Specific patients was given by the doctor who was Dr. Wasim al-Naqaidi. As you all know, internal medicine is targeting different aspects in medical field, so it was different by cardiology, nephrology, and so on. Presentations were bronchiectasis and encephalitis, and topic discussions included several aspects, as I mentioned, in addition to different dialysis types, CRRT techniques, bugs, and drugs. Tasks done was to order the different types of tube feeding for several patients, and it was by the guidance of the clinical pharmacist. And here are the references I used during my rotation. My third and very interesting rotation in Cleveland Clinic was the fourth endocrinology rotation. We started with regular morning rounds with the whole medical team for the endocrinology, and we had daily discussions with them along with the regular rounds. The physicians were very welcoming, and we had daily assignments with the small presentations daily. Also, we had to go to the anticoagulation clinic with the instructor, Dr. Ruba Dajani, and my presentations were hyperparathyroidism and hyperthyroidism. The second presentation was hypocalcemia post-parathyroidectomy. Topic discussions included some endocrine and metabolic disorders, along with osteoporosis, hyperlipidemia, fluids, electrolytes, and nutrition. My project was to design a table which classifies all electrolytes imbalances and their treatments, and here were the references I used. Medical ICU rotation was also very interesting. It contained regular morning rounds with daily case discussions and topic discussions. And ICU, my instructor was Dr. Nuran Salem. Her presentations I did was interstitial lung disease and SIRS post-endocarditis. Topic discussions were somehow similar to the cardiac ICU rotation because the target population is similar, including some like antibiotics, pharmacokinetics, HAB, VAB, CAP, and so on. Assignments was to dose some patients to vancomycin in ICU units, and the project was to prepare presentation about pharmacy involvement in palliative care field, which was presented to the palliative care committee. Here are the references I used as well. My last clinical rotation was the infectious disease rotation. It was to review daily the whole floors of the hospital with respect to ID problems. And then we go there for the afternoon rounds with the ID team with our recommendation. We had the chance also to recommend ourselves. We had also topic discussions with the Dr. Rania Lababidi, who was the instructor of this rotation. And she also gave us like some few examination with the board ID examination. And also I had presentations about Khaled-Post surgery and HAP. We had some few topic discussions like HAP, VAP, CAP, C. diff treatments, and endocarditis. And also during this rotation, I had the chance to go to join the Antimicrobial Stewardship Academy, which included the theoretical, practical sessions in different ID topics. Practical and theoretical, and by the way, we had to pass an exam and to score more than 80% so that we can pass and get the certification. And these were the references I used as well. Now we go to the non-clinical rotations, which is medication safety rotation. I learned basics about medication safety field in hospital and the daily medication safety incidents report and detection, if any, and we had discussions and assignments. Also, one report was submitted to the college, which included some tasks done by me and the role of clinical pharmacy in medication safety. I also completed the 3 different courses in medication safety, which is given by the Institute of Healthcare Improvement. My last rotation was the automation and informatics rotation, which is mainly IT-related problems like EPIC problems, medications registrations, healthcare medications ordering problems. They send some tickets to the IT pharmacist and he will solve it, or we go to the machines if there is any problem. We completed also different projects which was assigned to me on Excel, and also one report was submitted to the college which included some tasks done, and Dr. Wa'il Labib was my instructor. Regarding other activities, like joining some other academies, my first achievement at Cleveland Clinic Abu Dhabi was the CT training, where I was certified from US to join some research projects other than my master research project in the hospital. I also joined the antimicrobial stewardship as mentioned, and the IVPN Academy, which is showed in the pictures here. We also attended outside conferences like the 5th IVPN Pharmacy Conference and the pre-conference workshop cardiology during my cardiology rotation, as can be shown in the pictures. And inside hospitals, we had the chance to meet some different academia staff from several universities inside or outside the UAE with different hospitals, either also outside UAE, with different clinical workshops. Here also are the pictures showing some examples. Other activities were our morning huddle, as we always start with the family morning huddle, like daily updates, power of words, scientific information, guests, and theme of the month. I had also case presentations and medical meetings as shown. And Dr. Usama Tabara assigned me from the first month, which was July, to do the theme of the month. So my theme of the month that time was success is not final, failure is not fatal. It's the courage to continue the counts. And it was our theme of the month for July. We followed it. And this was my certification of completion of the whole training. And thank you.
Okay, fine. You can continue with the research presentation, Louna.
Okay. Okay. So is it showing now?
No, not yet. You need to end up this slide and then start that.
Okay.
Yeah.
Okay. So as we start, my name is Louna Khaled-Post. Our research today is about the evaluation of newly glycemic control with IV insulin protocol among both cardiac and non-cardiac surgeries in critical care patients. It's a retrospective study in Abu Dhabi, UAE. My presentation outline will include introduction and background, significance of the study, aims and objectives, literature review, research papers reviewed, methods and materials, results, discussion, conclusion, recommendations, limitations, and lastly, references. So regarding introduction and background, as we all know that several types of surgeries are associated with main side effects, which is acute hyperglycemia, specifically in critical illness patients in the ICU units. And also hyperglycemia is associated with several complications, such as making the patients more prone to several types of infections. And as known, 1 out of 4 patients are suffering from diabetes mellitus, which makes them at higher risk of cardiovascular diseases and events, and sudden events even. Globally also, it's known that acute hyperglycemia is associated with high rates of morbidity and mortality, specifically in critically illness patients. All these were reasons to update new insulin infusion protocols that will target tight glycemic control, which is used for hyperglycemia treatment. We have 2 available types of IV continuous infusion protocols. They are classified according to the type of surgery, 2, either non-cardiac surgeries, which is glycemic control protocol, and our targeted glucose by then is less than 10 millimoles per liter. And the other one is the cardiac glycemic control used post-cardiac surgeries, where our targeted glucose levels are less than 8.5 millimoles per liter, as we all know that cardiac patients should be on more tight glycemic control. The significance of the study is the first is to detect any presence of errors that will help in identifying the risk factors associated with the improper adherence of the IV insulin protocols. And this will help in improving the future IV insulin protocol guidelines. The aim of the study is first, as I mentioned, to detect the presence and absence of errors that will help in evaluating the adherence of the hospital practice regarding the glycemic control protocols. This is done in the critical care units in Cleveland Clinic Abu Dhabi Hospital after surgeries. So upon our aim of the study, the objectives were put to the following. First is to evaluate the appropriateness of the whole protocol by evaluating the safety and efficacy of the updated IV insulin protocols. Then is to evaluate the adherence of the hospital to IV glycemic control, cardiac and non-cardiac protocols. This is done by detecting presence and absence of the protocol errors post-cardiac and non-cardiac surgeries. Also, one important objective is to determine any incidence of hypoglycemia, which is considered as a glucose of less than 3.8 millimoles per liter and its proper management, or incidence of rebound hyperglycemia, specifically within the first 24 hours of drip stoppage, and it's considered a glucose of more than 10 millimoles per liter. One important thing is to highlight the role of clinical pharmacy and the endocrinology team in the hospital by following the proper protocol. Regarding literature review, I highlighted the main points which is related to our research topic. So firstly, as I mentioned before, I differentiated between the different types of protocols we have, and then we go into details about the main factors, which is first the nutrition type. As we all know that nutrition type is the main source of sugar in our body. So we should put specifically diabetic and critical illness patients on the best type of nutrition, like carb-controlled oral nutrition, or diaben for tube feedings if the patients were on NPO as they contain less carb amount. And we all know that carbs are converted to sugars in our body, so we need to control more. Also, one important factor is to know if the patient is on any corticosteroids, as we know that we have corticosteroid-induced side effects, so it's very important to control the patient. Now, the factors are, here we come to the main factors where the clinical pharmacists play an important role in. First, with starting the initial bolus dose with a proper dose, and then glucose monitoring, while glucose frequent monitoring is very important throughout the whole protocol, the cardiac every 1 hour and the non-cardiac every 2 hours, and also 2 hours post-drip stop when it's ordered, so that we keep the patient's glucose control. Then it's very important to have hypoglycemia early detection and the proper management if happens, and that's why the hospital have hypoglycemia protocol order automatically, so that we can save time if incidents happens. Two important factors are the proper switch of insulin from the continuous IV to sub-Q before stopping the drip, and this is the role of the clinical pharmacist. So we avoid any gap between starting the sub-Q and ending the IV, so we can avoid rebound hyperglycemias later on. And lastly, the reinitiation of IV insulin drip is evaluated upon each patient's need, and the endocrinology team role is very important as they will reduce errors and will help in making the whole protocol process appropriate. Regarding the methods and materials, our study was designed to include 50 cardiac and non-cardiac surgery patients that were registered between the 1st of January 2019 and 31st of February 2019. Our data was obtained from the medical record system, which was EPIC in Cleveland Clinic Hospital, after the REC committee approval. Our inclusion criteria included adult critically ill patients of both genders more than 18 years old, patients with history of diabetes or non-diabetics with acute hyperglycemia post-surgeries, patients with either previous glycemic control or cardiac glycemic control infusion orders, patients with different types of feedings, either oral or tube feedings, patients with cardiac surgeries, and patients with non-cardiac surgeries. Exclusion criteria included patients who are less than 18 years old, patients who are on multiple glycemic control or cardiac glycemic control infusion orders or overlaps, patients, cancer patients on chemotherapy treatment, pregnant women, psychosis patients, and lastly, patients with abnormal kidney profile. So regarding the results, so to go into deeply into the results, I divided upon the following. Firstly, I divided the patients upon the general sociodemographic variables, and then I divided them into with respect to the type of surgeries, and then with the endpoint with respect to the errors and factors, which are our aim in this research. So going into details with the general characteristics, and due to the time limitation, I won't be able to go into all details which are available in the master thesis. I will highlight some few points where after the exclusion criteria, we ended up with 44 patients with mainly male gender, where they are 74.9%, mainly with more than or equal to 60 years old. Mostly were on on cardiac type of surgery. They were mostly on obese or overweight. 81.8% were diabetes, and most of them were in the cardiac ICU. Here we can find the different types of oral nutrition and the division between glycemic and cardiac glycemic control generally. Here are the other factors into details for the glycemic control. And here we can find the type of surgery done, where we can find that coronary artery bypass was mostly done, followed by carotid endarterectomy. Cardiac surgery patients were 23 patients with mostly male gender, more than 60 years old, obese, and they were mostly diabetic. So we can find that the glucose monitoring during the cardiac glycemic control, where we can see that only 11.3 were on our targeted glucose. Non-cardiac surgery patients were 21 patients. Mostly they were male, with cardiac obese or overweight patients, and they were also on different types, diabetics on different types of nutrition. Here we can see also the glucose monitoring, where we can find only 2.27% were with our targeted glucose. Here is my aim. So factors and errors, as we evaluated the patients upon the presence of errors, where we can find majorly the errors were done in the cardiac type of surgery in males with obese patients and with history of diabetes, as we can see in cardiac ICU patients. And we can find different details upon the type of nutrition and insulin start and end date later on. So in order to ascertain the extent of adherence, I divided the factors into factor 1, the administration of initial insulin bolus dosage. Factor 2 was checking the glucose level for cardiac and non-cardiac patients and at the prescribed time. Factor 3, hypoglycemia management. Factor 4, monitoring glucose levels 2 hours after administration of insulin drip. Factor 5, switching the patient to sub-Q insulin before stopping the insulin drip. And factor 6 is following the insulin automated calculator. These factors are set upon the literature review and the studies reviewed before. So using the ANOVA test and the significance value of less than 0.05, I had the dependent variable, which is the general error, and we found that both factors 5 and factor 6 were significant, showing that they are important to determine the adherence to the guidelines of diabetes control. I re-evaluated again, taking into consideration the type of surgery as the dependent variable, and again we saw that both factors 5 and factor 6 are showing a significance value. They were found to affect the patient's type of surgery, either cardiac or non-cardiac. So regarding the relationship between the guideline adherence factors and the overall adherence to the guidelines, we can see that all factors were negative except for factor 3, which is hypoglycemic management, and showing positive value. So positive value means mainly mainly less errors, and negative values means more errors. So we need to keep a sight on all factors as generally. Then correlation between the type of surgery done and the factor of adherence to the diabetes control guidelines. Again, we can find only positive factor was factor 3, which is showing less errors. Regarding the discussion, which is shown into details in the master thesis, I tried to divide all the important points which is shown in my results and in my literature review, and I tried to summarize, like to search for studies done in all over the world, which is either supporting our results or having controversy results compared to ours. So I mentioned the majority patients, their age, the history of diabetes, overweight, and we can see different studies in US and Netherlands regarding that. Also, I included the type of nutrition, which is shown in a study done in China, which was supporting our result. Also, regarding the diaben, which is the tube feeding, which is done in Germany, a study done in Germany as well. Significant factors, which are our errors and are our main targets, like factor 5 and factor 6, I saw that mainly most of the studies are supporting our results. Some few studies were having controversy results. And lastly, our hypoglycemia, which is very life-threatening limiting factor. That's why we have little higher glucose targets in critical illness patients compared to other wards. And this was done in the nice sugar, huge study was done in England, which was supporting the same results. And lastly, we had only one hypoglycemia episode, which was managed properly, and we had studies showing the same results. Regarding the conclusion, the presence of errors indicated that non-adherence to some of the glucose control guidelines indicated more adherence to better follow-up, and that will result in better outcome, which affects the overall health in critical illness patients. Upon the study results and the literature review, I recommend the following. Firstly, the endocrinology team involvement, specifically the clinical pharmacist, where we have a clinical pharmacy department in Cleveland Clinic with a specialization of endocrinology, but I can't really find the value of their involvement in this study, so that they will help in achieving the adherence to glycemic control and to maintain a proper following to the protocol. Second is to develop electronic application connected to the hospital system. This will give a warning alert to the clinical pharmacist to remind them to switch the patient to to sub-Q insulin drip before stopping the IV insulin infusion. Thirdly is to involve the clinical dietitians team to follow up with the hospital healthcare team during the protocol, so that they can put them on the proper nutrition, either oral or tube feeding, so that depending on the patient's need. And lastly, more protocols factors should be collected, which are needed for further studies, which will help with more detecting protocols that errors that will help in also maintaining a proper protocol. My limitations was firstly small sample size, which interfered with more exploration. But although on the other hand, I can feel that it's a strength point, because as we all know that the critical care units have a smaller amount of patients compared to other wards. So that was a limitation. And other one is that our patients were from critically illness patients in different intensive care units, and they were all mostly diabetics. So we can't apply all the results to normal population. This was my references I used, and thank you.
Thank you very much, Louna. It was a very detailed presentation. I would just like to ask a few questions just to clarify.
Sure, doctor.
Okay, so I wanted to know first, is there a really consensus guideline on IV protocols at this moment that this hospital is using?
Yeah, they are using protocols specifically from US, because Cleveland Clinic is US origin, and they are using from the American Diabetes Association protocols. So that will help in our population as well.
I see. Is there any clinical pharmacist involved directly on this one, on making sure it's optimized?
Yeah, there is a clinical pharmacist which is specialized in a critical care unit. What from my observation there, even in my clerkship, I see that they are not involved in the whole process. So nurses are doing most of the things after the physician's order. And you saw that my recommendation is also to involve the endocrinologist, not only the clinical care unit pharmacist, also the endocrinology pharmacist, because they are board certified.
Yeah, very good. Okay. So you mentioned that there is a need for tight glycemic control in cardiac patients than the non-cardiac patients.
Yes.
Can you explain the reasons?
The reasons that, diabetic patients are more prone to be associated with cardiovascular events. So we mainly, even in the patients who are not having any cardiovascular events, but only diabetic, we need to have tight glycemic control to prevent any cardiovascular problems. That's why we need their glucose to be lower than the normal critical care units, other than the diabetic patients.
Okay. Were there any patients with infections at that? I mean, among your 44 patients, which could worsen the glucose control? Because I think infection is a very important point to address.
Sure, yeah,
Yeah.
specifically with wound healing after surgeries.
Yeah.
Yeah. So actually, the patients, like I can tell you from the general critical ICU unit, mostly patients are with infections, yes. But to be honest
Mhm.
with you, we had limitations in data collections with the approval of the hospital. So I couldn't collect the infection, the real infection type. But I can ensure to you that if not all, most of them were with type of
They
infections.
have, oh yeah,
Yeah,
right.
yeah, some of them, yes.
Yeah, I'm asking this question because I believe that it is an important factor for
Sure,
glucose
yeah,
control. Maybe it's
yes.
not just the lack of involvement of pharmacists, but it could be due to the infection that the glucose is not controlled well.
Yes, yeah,
So yeah,
specifically critical air patients with
yes,
pain, infections, all this may increase the glucose.
yeah, very, yeah,
Yeah.
right. Why do you think the errors are higher in cardiac patients? I'm just focusing on your objectives.
Yeah.
Why do you think? Yeah.
Errors are higher because to my view there, to my observation there were no endocrinology team involvement in the cardiac ICU. They were rarely consulted, and also the clinical pharmacist who's specialized in endocrinology, also they were consulted rarely. Maybe once I saw them during the 7 months I spent there. And also there was one important factor. I think it's important because the clinical pharmacist, which is available in the critical care unit, left that in this duration. So they had a gap between assigning another one. So they assigned 1 to 3 4 floors. So they couldn't
I
overcome.
see.
They left most of the work was left for the nurses.
I see. Very
Yeah.
good. So when I look into IV protocols, I always come across those surgeries that are long-term and those short-term.
Yeah.
It's quite easy to manage those short-term surgeries.
Mm-hmm.
Does it really have to relate with the duration of the time for surgery that your patients' errors were higher for cardiac surgery patients? Could it be the reason?
Maybe it could be because, cardiac surgery patients, as I showed you in my clerkship, it takes around 5 to 7 hours at least.
Mm-hmm.
So it could be one factor. And also, cardiac patients are more prone to develop higher glucose than normal. For example, someone is coming with cholecystectomy. Maybe it could be totally normal. It's only one problem. So glucose could be normalized faster than cardiac surgery patients.
All right, very good. If you are given a chance to just describe one very important point that you have learned from the whole process, can you describe that?
One important point is I will take there are a lot of important points, but
Mhm.
I will say an important point which is associated to my master field, which is clinical pharmacy department. It's very important to ensure that a clinical pharmacist is not only just to order as an automatic order, because we have computers, we have electronic sources where anyone can order, but the view of clinical pharmacy is to dose properly along with the physician. The physician can diagnose, can order, but the clinical pharmacist can relate all medications together, can dose properly, specifically the initial dose, for example, in our IV insulin protocols, can even know when to stop, when to reinitiate the IV insulin drip if needed, upon the glucose monitoring and upon the dosing the rate. It's very important. That's what I see. This is one important missing point, that the clinical pharmacy is only following electronically. We need to use our also knowledge along with the electronic things.
Yeah, very important point you have raised there. Yeah, that's why we are in the hospitals, I guess,
Exactly.
right? To
Yes.
use our expertise. Very good. Yeah, I have seen a lot of exclusion and inclusion criterias. Just
Yes.
can you describe your exclusion criteria because there are too many
Yeah. So our exclusion
reasons.
criteria mainly were, I will go back to the slide so we can,
Yeah.
okay. So here is the exclusion criteria. Okay. So
Yes.
patients who were less than 18 years old were excluded
Okay.
because at that duration, we didn't have any critical illness patient in the ICU with less than 18 years old on IV drip. Second one is patients who were on multiple glucose control, either orders or overlap. Was because, as I said, firstly, we had 50 patients, but then we excluded these 6 patients because some of them were having some overlaps, like they come for cardiac surgery, but by mistake they were put on glycemic control. So then they change again. So it was having some overlaps. I wanted to make it easier for the presentation, so we excluded those patients. Then cancer patients on chemotherapy treatment because first of all they were very few. And then lastly, also because, cancer patients are treated differently, little how, because they were on pain and chemotherapy is interacting with the glucose control and all this stuff. So it's making it more complicated. Pregnant women and psychosis patients, to be honest, and patients with abnormal kidney profile as well. I depended on this upon literature review and other studies, which are similar to our research. So they had the same criteria.
Okay, very good explanation. Thank you. That's all
Thank you,
for me.
doctor.
Very good
Thank you.
work. Yeah,
Thank you.
thanks.
Okay, fine. So now I have a few questions regarding your objectives. I can see there are several objectives, but I didn't find all the results here in the presentation. Maybe they are in the thesis. So
Mm-hmm.
just I want to cross-check each and every objectives over here. Starting with the
Okay.
first objective,
Yes.
uh, how you evaluate the safety and efficacy over here. What are the parameters you have used?
Yeah, so the main point of our safety here is to avoid incidence of hypoglycemia. As we know that hypoglycemia may lead to brain death and even total death. So our main objective regarding safety is to put the patient on a gradual decrease of blood glucose that will help prevent hypoglycemia and also put them on a glucose level with levels which is making them preventing also other complications related to hyperglycemia. Efficacy was evaluated upon to see to how extent the protocol was efficient to these patients, like how it was controlled, if the patients were controlled. That's why I included some of the graphs showing the glucose monitoring throughout the protocol, if they were really on the target or not.
Okay, so what is the overall conclusion for this objective? The safety is an efficacy. Efficacy is there is a good efficacy or low or moderate.
No, it was low efficacy, high safety because only one hypoglycemia incidence happened
Okay,
and it was properly managed, but
okay,
lower efficacy because, as we can see, mostly patients were not on the target glucose. That's why we raised up all this research.
okay. So that conclusion should be there in the thesis. Maybe here, because of the limited time, you cannot present, but try to
Okay,
include in the thesis. Second thing
sure.
about the evaluation of adherence. Again,
Mhm.
here, what was your evaluation? Means the adherence was low or high or moderate?
So the adherence was low. I showed it in the results 2 slides, which was showing the factors, the negative and the positive values. That the negative values shows that there is more errors, which showing
Yeah, you
somehow
showed about the errors.
non-adherence.
You showed about the errors,
Yeah,
but about the adherence or non-adherence, that
because we're evaluating the adherence upon the presence of errors. Are they
okay.
adherent to the guidelines upon these factors?
So you could have mixed up these two objectives then, because the result is same, the parameters same
Okay,
for these two objectives.
okay.
And what was the incidence of hypoglycemia?
It was only one incidence where the patient was having a
The
glucose
percentage,
level.
like percentage, in when you take out the percentage.
It is there in the master thesis actually.
Okay, fine. And how about the incidence of rebound hyperglycemia? It is also there.
It's available there also. Yeah,
Okay. So what
everything
was the
is available
percentage?
detailed there.
Okay. What is the percentage?
The percentage I need to recheck in the master
Okay.
thesis.
Okay, fine. And next about the regarding the
But
role of.
to be honest, like mostly all patients had rebound hyperglycememia afterwards. Like it's in 80s.
Okay. So because when you have mentioned the objective, you have to show in the result, like what
Mm.
was the incidence rate then. Okay. That
Okay.
is important.
Okay.
And about the role of clinical pharmacist based on the protocols, what was
Mhm.
the which factors were the role given for the clinical pharmacist and for
Mm. Mm.
endocrinology team? So that
Okay.
I didn't find here. That.
Yeah. So as I mentioned, the clinical pharmacist role in the literature review also, as mentioned, um,
But for your
mainly
study,
starting.
in your study,
Yeah, in my study.
what they did and what they could not able to do
Okay. Okay.
discussion should be
So
there.
in the hospital itself, you mean?
Yes, because
Okay.
your one of the objective for your study is the role to highlight the role. So when
Sure.
you have this objective, you have to mention what was the role and what was missing, what they could not able to do that. Anyway, in recommendation you have shown what should be there then. But during your study, what was there? What was their role that you have to highlight it that I could not able to see here then.
Yeah, I understand. So the clinical pharmacists there, they were missing, for example, some proper initial dosing. So this
Mhm.
was one important factor because the clinical pharmacist has the main knowledge of dosing medications. This one thing. The second thing was the switch from IV insulin to sub-Q insulin. They were mainly switching them after stopping the IV drip. This was leaving a gap, and this was resulting in having rebound hyperglycemia post the IV drip. Okay, and regarding the endocrinology team involvement, I see that when the physician is, because upon my study in the results, when I saw that the endocrinology team was involved, we had a proper protocol follow. So I think their order is important with the clinical pharmacist. They can manage these errors.
So this should be tabulated in the results, like
Mm,
what was the role, what they did, and what could not able to do that. In the recommendation anyway, you have presented what they have to do. That is fine.
yes.
But in the
Okay.
results, you have to show that since you have presented in the objective, you have to show in the results. Because generally for
Okay.
evaluation of any research, we will cross check your objectives and with your results. It should match that.
Okay.
Okay.
Sure.
And one thing is like uh, you did a study only for 2 months, January and February, right?
Yes.
And you have taken parameter of HbA1c, right?
Yes.
And HbA1c generally we'll see what is the duration.
3 months.
Yeah,
Every three
so
months.
that thing I think you can write in the limitation because
Mm,
your study is only for 2 months.
yeah.
So there will not be much variation if you take HbA1c within 2 months.
Now, for the HbA1c, we took, there was some, since it's retrospective, as you know, so there were some data which I saw in the EPIC, which showed that the HbA1c for the patients 3 months before the surgery, and
Okay.
then they retook the HbA1c on the time of the surgery. So it's not regarding the duration of the stay in the hospital. It's 3 months before the surgery and on the
Okay.
spot time of the surgery.
And even for efficacy of the glycemic control, we need to have
Mm.
at least 3 months data. Like from the start of your study, from January, what is the
Mm.
base HbA1c, and after 3 months, what is the base? So that will show
Yes.
your exact efficacy. That
Yes, sure.
yeah. So that is the one of the limitation we can mention there.
Actually, the main limitations I had because of the approval of the hospital, I couldn't collect, like, I see from my view, as I mentioned in the limitation, that more factors should be given, more duration and sample size should be also taken. But since the approval was little bit one limitation factor in the
Mm.
hospital, it was the main one, actually.
Okay. And regarding your patients, all are diabetes or
Not all, mostly. As I mentioned, they were about 80 something here in the results. They were 81.8 with history of diabetes.
36.
okay, eight patients they were not having diabetes.
Yeah, but they are having acute hyperglycemia post-surgery, maybe upon to the pain or stressful condition in the ICU after surgeries. This is normal. It may
Okay,
drop right back after.
okay. And I can see a lot of missing data here, like male and female. You have mentioned 30 male, 11 female. So it
Yeah.
shows the data only for 41. 41. What about three other patients?
Um, no, they were 44. I think it's just a mistake.
Yeah, maybe it's a typo
Yeah,
error. So
yeah,
try to
maybe
see. Yeah,
type
please
error.
try
Yeah,
to
yeah, they
try to
are
see.
44 after exclusion and inclusion criteria.
Yeah,
Mhm.
even for BMI, one is missing.
Yeah, I think it's only a typing error after the
Yeah, so try
thesis.
to see that if there are any missing, you have to mention missing.
No,
And
no
okay,
missings.
yeah,
They are
okay, if
only
it is
typing errors. Yeah,
okay, then please try to correct that thing there.
yeah, sure.
And initially, you have mentioned 50 patients, right?
50 patients were initially included. Yes.
Okay, but the study was done only on 44.
Yes. After the exclusion criteria, actually, I collected the data for the 50, full 50, but then when we excluded the 6 patients.
Okay, fine. Okay, fine. Thank you very much.
Thank you, doctor.
And, congrats for your graduation.
Oh, thank you. My pleasure.
Thank you.
Thank you, doctor. I'm sorry, I don't know the name. Samira. Thank you. Thank you,
Yeah,
Dr.
nice to
Samira.
meet you.
Thank you, Prof.
You're
Miza. Thank you,
welcome.
Dr. Ammar.
Thank you. Okay, fine, Rona. Means you can leave.
Okay, thank you.
Okay.